Catriona Bradshaw. She is Associate Professor at Monash University at Melbourne Sexual Health Centre, and she gave already an excellent talk in the morning symposium. She has special interest in bacterial vaginosis and Mycoplasma genitalium, and Catriona, we look forward now to your topics on clinical observations and experiences, please.
Thank you. Okay, I think people have probably completely had enough of Mycoplasma genitalium, and there'll be a little bit of repetition, so I might skip over some of the slides. So I'm talking really on management of this organism in the context of escalating macrolide and quinolone resistance, particularly in Melbourne. So I'd like to declare that we've received some research support from both SPEDEX and Hologic. Okay, so yeah, this organism, what has led to the mess that we're in with it really is that we treat it during presumptive antimicrobial therapy for our STI syndromes, NGU, cervicitis, PID, proctitis. And for over a decade, that's been predominantly with azithromycin in most countries. Some clever countries have retained doxycycline. And we've seen a recent, very sensible switch in the European and UK guidelines away from azithromycin use to doxycycline. But still globally, no testing for MG is available in most clinical services. And where it is available, it has generally been limited to specialised services that have access to labs that have developed in-house PCR assays that have targeted the MGPA or 16S. Ribosomal RNA gene. We all know that there are 2 commercial assays undergoing regulatory approval. These have both been TGA approved in Australia and I think CE marked. They have yet to be FDA approved in the US. We have the SPEDEX Resistance Plus, which has the macrolide resistance output, and the Hologic Aptima, a TMA assay. And these assays, while they're greatly welcomed by the field, are certainly going to result in a massive increase in diagnoses. A lot of increased emails and phone calls, I suspect, to many of us. And these infections are going to be really hard to cure in primary care with the recommended treatment approaches in our national guidelines. People heard this morning that this organism is error-prone, it has slow replication, so this has made it really prone to developing resistance, and the situation's been a lot worsened by the use of single-dose azithromycin for STIs. And we've sort of had the perfect storm, so we've now got in excess of 30%, in fact in excess of 40 to 50% resistance in countries where azithromycin's been commonly used. We've all seen this forest plot, so we've all seen this declining cure from 85% to 67% over the last decade. Now, most services with access to MG testing have not had access to resistance assays, and so macrolide resistance cases have predominantly been identified when they come back for test of cure or they return with symptoms to the clinical service. And it's at that point they get their second-line antimicrobial, which is often at least 3 weeks after diagnosis and first-line treatment. And so moxifloxacin has been the most commonly used second-line agent globally for the last decade. It's used daily for 7 to 10 days. It's been incredibly effective. Cure prior to 2010 in the studies, 100%. We've seen a recent decline down to 89%. But this is an expensive drug, it's not available everywhere, and it's uncommonly associated with serious adverse effects, which are very helpfully listed on the internet so that any tingle or twinge in your joint is immediately tendinopathy and you come back to your service. I say rather bitterly because I'm a bit fed up with it at the moment. So people who went to the talk this morning saw some of these bar graphs courtesy of Lei Zhang and Yusha Tao, who are looking at the prevalence of macrolide and quinolone resistance globally and undertaking a meta-analysis. I've just put this in here to highlight the difference between the prevalence of quinolone resistance in Europe, which is consistently low and less than 10%, the prevalence of quinolone resistance in Australia, which is 15 to 20%, and the alarming increases we've seen over a very short space of time in Japan from 10 to 50%. Now, what have we been doing in Melbourne? So like many places, we've been using a gram of azithromycin for MG and STI syndromes for at least a decade. We've seen a decline in cure. So in the mid-2000s, we were at 85%. By the end of that decade, we dropped to 69%. By 2013, we're down to 61%. In 2013, 1 in 3 patients with mycoplasma genitalium that walked in the door had pre-existing resistance. 1 in 10 we caused to develop resistance, so developed selected or induced resistance, and 9% had dual-class resistance. In 2014, we thought we'd have a look at extended azithromycin, and it wasn't really because we thought it would work any better in the context of high levels of resistance, but we didn't want to cause any more resistance. So we wanted to see, did it cause less selection of resistance? And unfortunately, in our population, it caused the same amount of selected resistance that 1 gram did. In 2015, we evaluated pristinamycin as a safer alternative to moxifloxacin, and we're rather disappointed to find that really, however we used it, it had a cure rate of about 75% in macrolide-resistant strains. Still, it remains an option in pregnancy and where quinolones are contraindicated. So things were pretty dire last year, and we sat down and made some serious decisions and thought it's really time for change. So in 2016, we decided we would implement a new clinical pathway. We're very fortunate to work in a service with a very obliging director and fantastic clinicians who are always ready for change, provided it's evidence-based. So we stopped using azithromycin. We showed everyone the data and we said it's really not a great thing to be doing, and we switched to doxycycline. We collaborated with SpeedX, we had been for some time, and through Sapir Tabrizi, and we implemented their diagnostic resistance assay that became accredited prior to regulatory approval in their lab. And we implemented sequence resistance guided antimicrobial therapy for MGen, at least that's what we called it. And our goal was ambitious. We wanted to reach the WHO 95% cure. So this is what our pathway looked like. Gonorrhea is dealt with outside of this pathway, so patients came in with their syndrome. We tested them for chlamydia and MG. We presumptively treated them with doxycycline, and the MG positives were recalled when they were on doxycycline, and a subset gave us what we called an on-doxy sample because we were very keen to measure the organism load. Patients who were macrolide susceptible received a high dose of azithromycin, 1 gram, then 500 daily for 3 days. Patients that were macrolide resistant went straight on to a week of citalfloxacin. Everyone came back for a test of cure, and those that failed the doxy-azithro pathway ended up on citalfloxacin, and those that failed the doxy-cita pathway ended up on pristinamycin. So that's basically what it looked like. So how well did this work? Well, we had macrolide resistance status and test of cure outcome data, so they had to return between 14 and 90 days to be included in this analysis on 260 patients over about a 10-month period. They'd all had doxy and they followed this resistance-guided pathway. We excluded 16 individuals at high risk of reinfection, defined as sex with an untreated or incompletely treated partner. We ended up with 244 who had doxy. So a third of these only were macrolide susceptible, 2/3 were macrolide resistant. So the macrolide susceptible went straight onto a gram and then 500 daily of azithro, and the macrolide resistance went onto the citalfloxacin. So how well did the doxy-azithro pathway work? We achieved our 95% cure, just. we squeaked in. So we had 4 failures. We were fairly impressed with this because regardless of the sample size and the confidence intervals, we were used to at least a 10% selected resistance rate. So this looked very promising to us. How well did the doxy-CIDR pathway work? You've got to remember we're sitting at about 15% quinolone resistance, so about 15% have PAR-C mutations, and we achieved a 92% cure. So for us, that had halved it. So again, we were very, very happy with that outcome. Now, we looked at selection of resistance, and we found it in only 3 out of the 4 failures, and really we need to sequence that, the remaining case, to be absolutely sure. But regardless, we're down to about 4% selected resistance compared to 10, 12, 18% that we've seen before with our 1 gram or our extended in patients who had not received doxycycline. Pre-treatment with doxy had a really striking effect on organism load. There was a 2.5 log drop, and in fact 40% were undetectable, not cured, suppressed. So some of those will be cured, but they were suppressed. And this was at a median at day 8. So this was, some of them, half of them were off their doxycycline. We had very good clinicians and very good patients, and we had excellent adherence data. So we had adherence data on over 80%, and you can see they were very adherent. By this stage, everyone's very engaged in MG. Patients are told they can't really get tested at many other places. They're very, very lucky to have the drugs, very lucky to have the new test, and it's all works really quite well. The antimicrobials were well tolerated. We were absolutely neurotic with citalfloxacin. We had to access it through the Therapeutic Goods Administration. We gave patients detailed pamphlets outlining every possible side effect they could experience. We talked to them about it, then they went to pharmacy to pick up the drug, and the pharmacy went through that again, which in many senses is a mistake because it over-elicits symptoms. But we also have had at least one patient who has not been happy, even though he's been deemed by a neurologist to be neurologically pristine. Her exact words in the letter. So 9% had diarrhea and 6% reported some tendon joint symptoms. We haven't had anything serious. But citalfloxacin is 150 Australian dollars, so it's expensive, it's hard to get hold of, and it's got obviously limited generalisability globally. We really believe doxycycline is having quite a profound effect in our pathway, so right now we've switched back away from citalfloxacin, and we're evaluating moxifloxacin following doxycycline, and we're reserving citalfloxacin for difficult situations, and in part this has just been a regulatory issue. Taking an opportunity making an opportunity out of a difficult situation. Monotherapy with quinolones is clearly not a long-term viable option, as it's likely to be associated with further increases in quinolone resistance. So we are looking at evaluating drugs in combinations. We've got evidence, as Jorgen says, from his lab of synergy. We don't have it of tolerability yet. So just quickly switching tack, MG in MSM, I think we've heard there's not really a lot of data out there at the moment. There's actually a few more studies than this. The studies that are out there are mainly STI clinic populations with prevalence ranging from sort of 1 to 5%. Most show no significant association with symptoms. A couple show an association with HIV. Mel Assessor at our clinic did a case series of 154 men with sexually acquired proctitis. Interestingly enough, she found that MG accounted for 21% of cases of proctitis in HIV-positive men, which was as common as chlamydia, but it was less common, accounting for 8% of cases in HIV-negative men. And if you look at the pie chart there, it's there as a cause. It was on its own. This is not co-infection. But it is, as we always see, just a little bit more indolent than chlamydia. So at the moment we're doing a study called the M&M study. It's a study of 1,000 MSM without urethral or rectal symptoms, so asymptomatic MSM. We're screening both sites, HIV positive and negative MSM and PrEP and non-PrEP users. It's receiving funding support from SPEDEX. MGen, we're looking at site-specific prevalence, macrolide resistance and antimicrobial response. Now I'm just saying this because I've felt a little bit uncomfortable about this. We are not doing this to advocate screening. We are doing this because we want to understand the magnitude of the problem. What we do with the results is going to be challenging, and when you see them you'll probably see why it's going to be challenging. I'd like to, so these are our interim results. So we've actually recruited over 800 now in a fairly short space of time. The prevalence of MG is approaching 10%, so 9.5. So effectively 1 in 10 asymptomatic MSM walking into our service just for a checkup have MG. And there's a staggering 86% macrolide resistance, so it's basically universal resistance. It's predominantly a rectal infection, so 7% have rectal MG, 3% have urethral, and we've got a couple of cases of dual site infection, so that is actually not common at all. Now if we look at our subgroups, we've got a bit over 90 HIV positive men at the moment and 4.5% have it. We've got 600 HIV negative non-PrEP users. I might add actually that a chunk of these are coming in to start PrEP, and we have to look at this separately. So we're going back to look at that. So it's 10% in the non-PrEP negative users, and it's 11% in the HIV negative PrEP users. So those data, as I said, they're interim data and they're going to change. So yeah, take-home message, 1 in 10 men, asymptomatic MSM have it, and over 80% are macrolide resistant. So where to now? Well, we've heard from everybody today with a whole range of talks that we've got high levels of macrolide resistance, we've got the emergence of quinolone and dual-class resistance. We certainly need to be implementing surveillance. And this is probably the meeting we really need to start talking about a GASP equivalent type, looking over there, set up, we can found it. And we need to be reviewing the widespread use of this drug, and some nations are already doing that and leading the way. Use of resistance assays is really important. It enables you to individualise antimicrobial therapy, and as you've just seen from this interim data, it helps optimise early high-level cure, which really has not been achievable at all to date. There we go. Generation assays will really need to incorporate quinolone resistance targets, and people are working on that. That will help us further refine our clinical care algorithms and really enable us to select our antimicrobials appropriately and safely and shorten time to cure. And I think, as we've all said today, we have an obligation to be really careful with the use of our existing and new classes of antimicrobials. We really use them wisely. And I think we need to consider a range of treatment approaches with what we have currently, and that may be something like the use of doxycycline followed by resistance-guided selection of a second agent, and ideally combination therapy, extending the doxy through and adding a second drug once we've shown it's tolerable. So I'd like to thank everybody listed on this slide, particularly Tim, who has allowed me to present these interim data today. He has presented the MSM data, I think, in a concurrent session, and will present the treatment pathway data in a lot more detail on Wednesday afternoon. Kit Fairley for his ongoing support, Leigh and Yusha for their modelling, the Royal Women's team for all the lab work, Jorgen as usual, and Magnus and Lisa and the SPEDEX team. Thank you.